What you see in the physical world is entirely at the mercy of where you stand. An object that looks distorted or diminished from one vantage point instantly corrects itself the moment the observer shifts their angle. When we look at global, objective data regarding human anatomy, specifically penile dimensions, the numbers are remarkably consistent. A comprehensive meta-analysis of measurements across World Health Organization regions paints a clear mathematical picture of the human baseline. This graph displays worldwide averages for objective length and circumference. The vast majority sits within a tight, predictable statistical center, but plots self-reported perception against physical measurements, and an anomaly appears. The cyan line shows how men rate themselves, ignoring reality, skewing aggressively left. The vast measurable physical deficiency that causes so much anxiety rarely exists. The crisis is happening within the mind's internal rendering engine. To understand why that cognitive error is so universal, we have to look at the physical geometry of how a human observer evaluates their own body in space. Self-assessment requires looking down from an eye-level perspective. This steep downward viewing angle creates a well-documented optical phenomenon known as foreshortening. Foreshortening compresses the visual depth of an object along the line of sight. Compared to an objective side profile view, the object directly below the observer's eyes is visually compressed, making it appear significantly shorter than it actually is. The eyes accurately transmit this compressed image, and the brain accepts it as absolute truth. The observer is continually feeding themselves a corrupted, miniaturized visual dataset of their own anatomy. This insecurity is a byproduct of sensory geography. The brain is simply executing a calculation based on corrupted geometric input. When a mind processes that corrupted visual data over months and years, the initial moment of doubt begins to hardwire itself into the brain's daily operations. This clinical flowchart illustrates how a common anatomical insecurity fractures into pathology. While many men remain in a steady state of mild anxiety, others cross a threshold into clinical body dysmorphic disorder, or BDD. In this looping state, anxiety overrides normal behavior. Clinical studies show severe disruptions in sexual functioning, with the individual avoiding intimacy, obsessively checking mirrors, and withdrawing from social routines that trigger their specific fears. The delusion becomes fixed. It isolates the individual, expanding outward until a localized concern over a single body part dictates their entire psychological framework. Past this threshold, the physical body ceases to matter. The disorder is sustained by the mind's broken processing loop. The logical medical response to a patient suffering from anatomical insecurity is straightforward. Provide them with hard, undeniable proof that they are normal. Doctors attempt to break the delusion by introducing reassuring data, taking clinical measurements to prove the patient aligns with the global average. But the dysmorphic mind actively repels the objective truth, overriding physical reality to protect its internal delusion. Clinical charts are ignored. Peer-reviewed comparative studies are dismissed. Even clear visual evidence is rationalized away by the patient. You cannot apply a tape measure to a psychological disorder. Once the dysmorphia loop closes, treating the physical reality is useless. Left unchecked, this escalating feedback loop reaches a tragic terminus. The most severe, end-stage psychiatric condition resulting from this untreated dysmorphia is classified as small penis syndrome, a state of such profound distress that it completely destabilizes the individual's perception of their own worth and safety. Medical investigators rely on a framework known as a psychological autopsy to reconstruct a patient's state of mind leading up to a tragedy. This diagram traces that final trajectory. The distress of this syndrome is so all-consuming that it can impair a person's situational awareness and judgment. In extreme cases, investigators have used these autopsies to link the syndrome to fatal vehicular accidents, where the driver's mental health crisis became so acute that it overrode their focus on the road. A geometric trick of perspective, looking down and misjudging physical space, can snowball into a fixation that eventually triggers a total psychological collapse. Body dysmorphia is a structural distortion of reality, capable of overriding every instinct for self-preservation. True clinical intervention requires a different approach entirely. We have to treat the mind, because the physical body was never the problem.